Noise of waiting.
We can start. We can start.
Okay, sir. So let us start it. So I welcome you all to this today's session. This is a purely medical physics session, and we all have been struggling in our practical life for gap correction. But with the development of science and medical physics, now this is no more gap correction. Now it is gap management. So we are very delighted to have Dr. T. Ganesh with us.
Sir, I cannot hear your voice.
Noise. Kamal, unmute
Kamal
karo.
went offline.
Unmute karo.
Sorry. So T. Ganesh is a known face to our country, and he have been a faculty in our various previous program. So it is a pleasure for us to welcome Dr. T. Ganesh to this program, and we are very happy to see some very senior medical physicists like Dr. Zakaria and Dr. Anupama is also there, and Kartik is a co-host with us. So I'm not talking about Kartik, but there are many other physicists, and I'm sure many more will be joining us. So now, as a culture, I would like to request our President, Professor M.A. Hai, sir, to formally start the program so that then Dr. T. Ganesh can start presentation. Professor Hai, sir.
Okay, thank you, Kamal. I shouldn't go for any formalities, anything like that. I welcome all of you. And my gratitude to all of you for coming and joining our program. And without delay, I think we should start. I shall now request Dr. Ganesh to please start the lecture.
Right. Thank you very much, sir. And at the outset, I would like to thank Professor Kamaluddin and also Dr. Karthik for giving me this opportunity, and also my sincere thanks to Oncology Club for providing this chance to me. I will now share my screen. Yeah, I hope all of you are able to see my screen.
Yes, it is visible.
Okay. Place a pointer. Okay, so over the next 45 minutes or 50 minutes or so, we shall be seeing about how we should be moving away from the traditional gap correction method that we often talk about to gap management. And this is nothing but all these things are being explained in the RCR guidelines, Royal College of Radiology guidelines. And this document was published just about 1.5 years ago, January 2019. In fact, this is fourth edition on guidelines for the management of unscheduled treatment interruptions. And the first three editions came in 1996. That was the first edition. And then 2001, the second edition. And then 2008, the third edition. The fourth edition came in 2019. Oh, I'm not able to see once again. Okay, let's look at a typical 7-week treatment course. What happens during such type of a long treatment course? It's quite normal for us to come across treatment gaps, especially in this part of the world, in developing countries like ours. We come across many type of treatment gaps due to various reasons. The patient might not be turning up due to some personal reasons, or patients may develop some kind of reactions, or there may be some breakdowns in the treatment machines. So due to various reasons, gaps can occur, and such type of gaps can occur in the early part of the treatment course, maybe say like loss of whole third week or fourth week, or during the later part of the treatment course, maybe in the 6th week or 7th week. Or gaps can be not necessarily that they have to be only 1 week. It can be from few days to more than weeks also. So both the durations of the treatment course and as well as the treatment interruption can vary in a large way. The question is, how can we mitigate the effect of such unscheduled treatment interruptions? How can we mitigate? Oh, I'm not able to move my slides. Okay. Let's talk about a 7-week treatment course comprising of 35 fractions, each fraction 200 centigrade. And what happens is that the patient after 5th week, that is after receiving 25 fraction, due to some reason, there is a treatment gap of 14 days. So usually what happens is that when the patient comes back after this gap of 14 days, the treatment would start without asking a physicist or anybody else. The treatment would start, and remaining 10 fractions, so 8 fractions would be delivered, and after about 8 fractions or 9 fractions, physics will be asked this question: how many more fractions should be given for this patient to account for an unscheduled treatment gap? That is how usually in Indian clinics the things will happen. Treatment will start, and when it is about to complete, when it is only 1 or 2 fractions left out, physics will be asked how many more fractions to account for an unscheduled treatment gap of this 14 days. Oh, there is some problem. I'm not able to move it. Okay. So the usual answer, or the usual thing that the physicist does, is that we look into the TDF tables. So TDF tables like this for several fractions per week are available, and they were published in BJR in 1973, almost 50 years ago, by Dr. Arton. So this is the source that we rely on. And how do we do it? We do it in this way. For this 7-week course of 200 centigrade 35 fraction, the planned TDF is 115 derived from here, and delivered TDF after 25 fractions is 82. Now, a gap of 14 days, what does that mean? The decay factor will be 0.96 if you use this formula of T by T plus R to the power 0.11. Decay factor will come to 0.96. So 82 we have already delivered, multiplied by decay factor 0.96, it comes to 78.7. That is the effective TDF remaining. So how much TDF we have to give? 115 minus effective TDF 78.7, that is equivalent to 36.3. So what we see, we interpolate in this table between 10 and 12 fractions. If you look at the values here for 200 centigrade per fraction, the value comes as 36.5, very close to the one that we are looking at. So that means for 11 fractions, we have to deliver more treatment. In all, already delivered 25 fraction, and we have to give 11 fractions instead of 10 fractions. So total 36 fractions. So instead of planned 35, we are giving 1 fraction more. So just 1 fraction more to account for 2 weeks gap. And then every one of us, we feel happy that we have very nicely addressed this gap of 14 days. However, the RCR approach, the Royal College of Radiology approach, which has been explained in this document, is completely different, both conceptually and as well as fundamentally, they are different. Conceptually different means it is no more looking at how to increase the number of fractions. That is not the solutions that we are looking at. It's not about how many number of fractions more. That is not the solution. Instead, the focus is on the overall treatment time. We call it as OTT. The focus should be on the overall treatment time. That's what the Royal College of Radiology tells us. And then how to complete the planned treatment within the planned overall treatment time. That should be the focus. We should try our best to complete the planned treatment within the planned overall treatment time. There are certain basic considerations before actually we go into looking at the equations. There are certain basic considerations considered throughout this document. Like the first thing is that why actually we have to focus on the overall treatment time, because we know very well that any kind of prolongation of the overall treatment time is going to increase the risk of the local recurrence. There have been enough literature available to tell us that even a day gap means about 1.4% reduction in the local control. And this happens due to rapid cellular repopulation of the tumor cells. And which are the most affected tumor types? Most affected tumor types are the all type of squamous cell carcinomas, especially the head and neck squamous cell carcinomas, cancers of the cervix. These are the common cancers in our part of the world. Lung, both NSCLC and SCLC, cancers of esophagus, medulloblastomas and PNET, and anal squamous cell carcinomas. Tumors where effects are uncertain means it is not that significant, but still effects are there, like glioblastomas, transitional carcinomas of bladder, adenocarcinomas, breast cancer. Here the effects are uncertain due to prolongation of the overall treatment time. And then if we ask whether the timing of the interruption, whether the treatment gap occur during the early part of the treatment course or during the late part of the treatment course, if we ask, the position of the interruption does not yet appear to be significant according to the document. Only thing is that when the gap occurs during the later part of the treatment course, then in that case, managing gaps will be very difficult. It becomes difficult to address any gap that occurs during the later part of the treatment course. And another consideration is that accelerated repopulation. It starts 28 days after the start of the radiation treatment. That is T delay. What is T delay? We will see later on during the this presentation. Now, when it comes to prioritizations in a busy clinic, when many patients are being treated, and if there are gaps, and if there is a need to prioritize that which patients we have to look after or which patients we have to focus on in order to complete the treatment within the planned overall treatment time, we have to give maximum importance to patients who have relatively short tumor volume doubling time, and also patients who are being treated with radical intent. So these are the patients who belong to category 1, on whom we have to focus our attention, or we have to give prioritization. And here in this type of cases, the treatment duration shall not be prolonged by more than 2 days. It should not be prolonged by more than 2 days, whether the patient is being treated only with external beam radiation therapy, or if it is a combination of EBRT and brachytherapy. Whatever it is, we know even if we are going to give brachytherapy, we know that when we want to give brachytherapy, and that overall planned treatment time should not be exceeded. Patients with the slower growing tumor types will come under category 2, on whom we can give a little bit of relaxation. That doesn't mean that we can give a lot of relaxation. Here, our aim is that the treatment duration, as much as possible, shall not be prolonged by more than 2 days. The earlier, it should not be prolonged, but here, as much as possible, it shall not be prolonged by 2 days. And if interruptions happen for more than 5 days, then we have to give certain kind of combination. So these are the examples, like breast cancer, adenocarcinoma of the breast, or transitional cell carcinoma of bladder, and carcinoma prostate. And the lowest prioritization is for the patients who are being treated for palliative reasons, because first of all, overall treatment time is so less here, and it is not that critical in achieving the desired palliative outcomes. And it is very unlikely that in such a short overall treatment time, there will be any kind of breaks occur. So patients will most likely will complete their planned treatments within the overall planned treatment time, or at the most, even if there are 1 or 2 days, it's not going to be that critical. So there shall not be any, that should not be, there should be no need for any patient to experience any break. Now we come to the most important slide of this presentation, the two equations. I'm sure that almost all of us, we are aware of these two equations. This is the BED equation for the normal tissue, and this is the BED equation for the tumor. So you can see here NB, N is the number of fraction, B is the dose per fraction, and alpha beta is the uh, alpha beta value for the normal tissue, which is normally taken as 3 gray. And for tumor, you can see there is a factor called K. K is the daily BED equivalent of repopulation, and T is the overall treatment time, and T delay is the one that I told initially. T delay is the time elapsed from the beginning of treatment to onset of rapid repopulation. The 2 points that we have to see is that, number one, for normal tissues, only the total dose, capital N multiplied by small b, and the dose per fraction, they matter. Overall treatment time doesn't play any role here. That means the normal tissue will not forget whatever dose it has received. Overall treatment time, even if it is prolonged, it will not forget the dose that it has received. That is the meaning of this equation. You cannot find T here. However, you can find T here in this BED equation for the tumor. So for tumor, overall treatment time is an additional factor, and any prolongation of the overall treatment time because of the way of the because of this equation is going to reduce the tumor BED. You see here minus, so any prolongation is going to reduce the overall BED for the tumor. So these 2 points we have to keep in our mind. One is overall treatment time extended, normal tissue is not going to forget the dose, but however the tumor BED, any overall treatment time increase is going to reduce the value. So what should be our methodology? If there is a treatment gap during the treatment course for the patient, then what is the way to do the biological correction? How shall we go about in the management? The first thing is that we have to concentrate on the normal tissue BED value. We have to look at the normal tissue BED value and try to identify what can be done without exceeding this tolerance. We have to give maximum importance to the normal tissue BED and find out that what can we do for the patient without exceeding this tolerance. And if it is not possible, then explore and evaluate what kind of compromises can be done. We are going to see the examples. For example, there is a treatment gap occurring. The patient is reporting for treatment after the gap, say after the gap of 1 week or 2 weeks, whatever it is, patient is coming back after the gap for the treatment again. Before you start, not at the end of the gap, not after delivering the remaining 8 fractions or 9 fractions, but before the treatment starts, after the treatment gap, find out how much of remaining treatment time is there. Because on fraction 1, we know that when is going to be the last fraction. So we know what is the overall treatment time. And when the patient comes back, we have to find out what is the remaining treatment time. And how many number of fractions are still there to be delivered, that you find out. And after that, determine whether there are ways to deliver the remaining fractions without altering the planned overall treatment duration. Critical question. Whether there are ways to deliver the remaining fractions without altering the planned overall treatment time. Is it possible? If the answer to this question is yes, then there is no need for the biological correction. In other words, we don't have to use those 2 equations that we saw in the previous slide. However, for this question, if the answer is no, then in that case, we have to follow the steps that are explained in the next slides. When the answer is no, then this is the approach. First, calculate the normal tissue BED for the prescribed schedule and find out Until the gap occurred, how much of normal tissue BED has been delivered using equation A in that previous slide that we had seen, and find out the difference between these two. The difference between these two will tell you that how much more you can give for the normal tissue BED. And then review the various treatment options, whether you can go for hyperfractionation, like change in the number of fractions n, or can you go in for altered fraction sizes, can you change the dose per fraction size, or whether you can deliver twice daily fractionation. So try to use a permutation combination of these options and find out which will likely result in minimum extension to the treatment time. That is the key point, that you have to find out a solution in which there will be minimal extension of the overall treatment time. This is the most important approach, minimal extension to the overall treatment time. And then calculate the required dose per fraction to reach the required normal tissue BED. And for the selected option, okay, you have selected some option, calculate the associated tumor BED, because now the fraction size has changed, the number of fraction has changed. So you have to calculate what is the associated tumor BED, equation B. And when you are calculating, do not forget to look at the fact that the overall treatment time now has extended. And then review the final tumor and normal tissue BEDs from selected option. And if the tumor BED is significantly lower, then try to fine tune the compensation to arrive at a reasonable compromise. So how do we do that? I am going to show you four typical examples. All examples pertain to the typical head and neck case, 70 gray. We have to deliver over 35 fraction over 46 days. If we calculate 35 fractions will be delivered over a treatment duration of 46 days, right? And 5 fractions per week. Now, the example 1 is a very simple case. Simple means very easy to address. Example 2 is little bit difficult. Example 3 is more difficult, and example 4 is complex. So 4 examples, and let us see that how 4 examples are handled. The treatment began on a Monday, this course, and the planned overall treatment time is 46 days. After 10 fractions, gap occurs. That is 2 weeks treatment over, loss of all the third week. 1 week completely lost, patient did not come for treatment. Now treatment resumes on a Monday after the gap. How many more fractions are to be given? 10 fractions delivered, overall 35 fractions. We have to give 25 fractions more. To maintain the overall treatment time, the available number of days is 26. How it is 26? Including the weekends, there are 3 weeks left out plus another 5 days, so total 26 days. So weekdays, one option is treat on all weekdays 20 fractions plus 5 of the remaining 6 weekend days, or treat twice on 5 of the remaining 20 treatment days, and Fridays are a good choice. When I say this, I have prepared these slides for our Indian scenario. Here we treat from Monday to Friday, and Saturday, Sunday are holidays. So you have to see in that context. We treat from Monday to Friday, and after that Saturday and Sunday are holidays. I will put it pictorially because it may be a little bit difficult to understand. That is the planned one. You see here 5 fractions first week, then Saturday, Sunday red color, no treatment given, square. The filled circle means treatment delivered. So 1, 2, 3, 4, 5, 6, 7. So 7 weeks, and 1, 2, 3, 4, 5, 6 weekends. Fine. That is the planned overall treatment time. 2 weeks patient came, 10 fractions received, and then third week patient did not come. The empty circle, that means the treatment was not delivered. Now patient is reporting on Monday. So what can we do? We can now treat on all the remaining planned treatment days. In addition to that, we can also treat on the first weekend, Saturday and Sunday. And then when the next weekend comes, we treat on a Saturday. And then again, next weekend, Saturday and Sunday also, we treat. Okay. So 5 fractions missing here, and here we have accommodated those 5 fractions. What did we achieve? The overall treatment time did not exceed. That is the key point I told earlier. Overall treatment time shall not be exceeded. Now, another way of approach, instead of treating on Saturday and Sunday, let us say that it is practically not possible. So when the patient comes back, first Friday you treat twice a day, and next Friday again twice a day, and then once again third Friday you treat twice a day. 3 fractions you have accommodated, and then in the last week you treat twice on Tuesday and twice on Friday. So another 2 fractions. So 1, 2, 3, 4, 5 accommodated all the 5 missing fractions. But what did we achieve? We achieved that we did not exceed the overall treatment time. That's the important thing. Now we move over to example 2. Same thing, 46 days, 70 days, 35 fraction. The only thing is that now loss of all 6th week, that is patient has been treated for first 25 fractions, and after that 10 fractions are remaining. After the gap, the treatment once again resumes on Monday, which is the week beginning day of the 7th week, to maintain the overall treatment time. See, 5 weeks gone, 1 week gap, 6th week gone. So when the treatment is resuming, it is on the 7th week. To maintain the overall treatment time, available number of days left out is only 5 now. So we can do one thing. One approach is treat twice daily on each weekday of the final week, that is 5 days for 10 fractions, or if possible, use the weekend before the final week plus twice daily on Monday, Wednesday, Friday, that is 7 days for 10 fractions. Let's see pictorially what I mean by this. So here that is the planned one, and what has happened for this patient, 5 weeks, patient received 25 fraction, fine, but 6th week patient did not turn out for some reason. So now patient reported on Monday. What we can do is that on all 5 days deliver 2 fractions every day. So 5 fractions missed, here 5 fractions accommodated. We did not exceed the overall treatment time. Or you can do one another thing. If you feel that this will be too much on the patient, you treat on Saturday and Sunday also. Ask the patient to come on Saturday and Sunday. You treat Saturday and Sunday. That means that the remaining 3 fractions you can stagger out on Monday, Wednesday, and Friday. Once again, you have achieved that you did not exceed the overall treatment time. That is the way that we can keep both tumor BED and normal BED intact. So this is example 2. Now coming to example 3. Here it becoming more difficult. What happened? Patient received 6 fractions, 6 weeks of treatment, and patient did not come for the 7th week. The entire 7th week, patient was absent. So no way that overall treatment time can be maintained 46 days. It has to be extended, because when the patient comes back after the treatment gap, already 46 days are over. Means we cannot keep both the originally planned BED3. When I say BED3, the suffix 3 denotes that it is for normal tissue. BED10, suffix 10 denotes that it is for tumor. So because the overall treatment time has extended, we cannot have the bread and also I mean, there is some saying, no, you cannot have both bread and eat it also. So we cannot maintain both the BED and as well as the tumor BED. Normal tissue BED for this course, if we substitute the values and if we calculate, it comes to 116.7 gray suffix 3. Remember this gray, when I say it is not physical dose, it is biological dose. So gray 3. Tumor BED is 67.8 grade 10. Okay, when you substitute the values. So these are the values. So now what options do we have? Option number one, keep the normal tissue BED unchanged. That is why here I have put green. Normal tissue BED unchanged, planned is 116.7 and here 116.7. If you are keeping this one as unchanged, obviously you will have to compromise on the tumor BED. When I say compromise, we have to lose some amount of tumor BED. So tumor BED will not be anymore 67.8. In this approach, option 1, the tumor BED will go down. That is why red color arrow going down. Here we are maintaining it green color. So this is the way that we can do entire seven. I mean, this is the planned one, and the entire 7th week patient did not turn up. Now we have to extend the treatment, overall treatment duration. There is no way out. One way is to just deliver when the patient comes back, remaining treatment you deliver these 5 fractions. What is the resultant BED values? Normal tissue BED is kept unchanged. By delivering such 5 fractions, normal tissue BED will not be changed. It will remain unchanged. Same total dose, same dose per fraction. Nothing happens to the normal tissue BED. But however, overall treatment time has now extended by 7 extra days. That means loss at the rate of 0.9. You remember that the K value I told 0.9 BED per day. So 7 extra days, 0.9 BED, you lose a value of 6.3 BED, which is equivalent to now 67.8 minus 6.3 equal to 61.5. In physical dose, it is equivalent to delivering a dose of 63.5 as against the 70 gray that we had planned, originally planned. So tumor BED goes down to 61.5. One another thing we can do, instead of treating on Monday, Tuesday, Wednesday, Thursday, Friday, we can start the treatment on Saturday itself, Saturday, Sunday, Monday, Tuesday, Wednesday. Please forgive me once again because I am speaking in the context of Indian treatment days. So for us, Saturday, Sunday is a weekend. So you have to interpret it in that way. So treat on weekend also, Saturday, Sunday, Monday, Tuesday, Wednesday. And what did we achieve? We achieved that instead of 7 extra days, we are now extending the treatment only to 5 extra days. That means loss is controlled. So now instead of 9.3, the loss is only 4.5. And that is equivalent to, instead of 63 gray, now it is only 65.4 physical gray. Tumor BED is still less. One more thing we can do, start on Saturday, Sunday, Monday, but Saturday you deliver 2 treatments and Monday 2 treatments. You are further reducing the overall treatment time, only 3 extra days by treating on weekend and also twice daily. And here only a fall of 4% in the tumor BED is observed, that is 67.2 gray. So this is one way of approach. That is option 1, where we have to keep the normal tissue BED unchanged and compromising on the tumor BED. Now, the radiation oncologist treating the patient prefers, no, I don't want any compromise on the tumor BED. I am bothered about the tumor BED. I am willing to take risk on compromising the normal tissue BED. So if that is the decision of the radiation oncologist, keep the tumor BED unchanged. That the way tumor BED planned original value 67.8, I am keeping it green. If you are compromising on the normal tissue BED, then it will go up. That is why red arrow going up, pointing up. It will not be any more 116.7. It will be more. Let's see the example. So once again, this is the planned one, and this is what happened for the patient. So what we can do is that we start treating on Saturday, Sunday, Monday, Tuesday, Wednesday. But look at the circle. The circle size is bigger. That means dose per fraction is now more. Treated on weekend, only 5 extra days, and tumor BED will remain unchanged, 67.8 green color. However, normal tissue BED will go up 124.5. which is 6.7% excess, or it is equivalent to delivering a dose of 74.7 gray, right? Dose per fraction will be 2.62 gray. Now, if for some reason, if the radiation oncologist feels that no, I am not comfortable with 2.62 gray, then you can take a middle approach, that is compromise on the tumor BED and also on the normal tissue BED. So instead of 2.62 gray, you can keep it as 2.3 gray. So tumor BED will not be the planned anymore 67.8, it will be slightly less. But however, normal tissue BED will not be that high like in the previous example. It will be equivalent to delivering only 72.2 physical grade to the target point. Now that is the example 3. Now moving over to the most difficult example 4. Here the patient doesn't turn up for 6th week and 7th week. 10 fraction at a stretch patient has lost, and patient is coming after this gap of 14 days. A significant part of the treatment is yet to be delivered, that is 10 fractions. Now what options do we have? Once again, we have got option 1, and in this option 1, that is pathway 1, keep normal tissue BED unchanged green, compromise on the tumor BED red. And here what do we do? This is week 2, week 3, week 4, week 5, week 6, week 7. When the patient comes back after the gap, then we have to deliver remaining 10 fractions. So 10 fractions we have to give subsequently. After this gap of 14 days, we give 1 week of treatment, another week of treatment without altering the dose per fraction. You see here same circle, and in that case the normal tissue BED we have not violated because we have just delivered the same total dose, same dose per fraction. But however, the tumor BED is now 55.2 gray as against the 67.8 gray that was originally planned, a very significant reduction. So what can we do? We can try to minimize the extension of overall treatment time by increasing the dose per fraction, but this approach can be taken only if we are treating 1 fraction per day. Some of the patients we might be treating 2 fractions per day. In that case, such type of approach cannot be followed. So when we are treating the patient with this 1 fraction per day, we can try to minimize the extension of the overall treatment time by delivering 5 fractions only. Instead of the 10 fraction, deliver only 5 fraction. By that way, we can complete the treatment in 8th week itself instead of extending to the 9th week. So treatment is extended only by 7 days. You see here, this is what happens. So only 1 week extra, but fraction size is increased. So normal tissue BED, in spite of increasing, normal tissue BED has not increased because that's how we have calculated. Overall treatment time has been extended by 7 days. Dose per fraction has to be 3.22 gray into 5 fractions. However, the tumor BED, earlier it was 54.4 by going into 2 weeks extra, but now only 1 week extra. So tumor BED is 58.8, or the physical dose is equivalent to 60.8. One another thing we can do, instead of compressing the 10 fractions into 5 fractions, because of which the dose per fraction size is very high, here we can deliver the 10 fractions over 7 fractions. So OTT extended by only 7 days, but however, the treatment is staggered over 7 fractions. So instead of 3.2 gray, now we can deliver 2.57 gray into 7 fractions. Still BED will be less, but not that less as in the previous slide. One another thing that we can do is that here like this, that same 7 extra days, but we deliver 11 fraction by treating on certain days twice daily. So OTT extended by only 7 days, dose per fraction is 1.87 gray into 11 fractions. Tumor BED loss is further controlled and it is only 8.7% loss. Now, if we have to keep the tumor BED unchanged, then in that case we have to compromise on the normal tissue BED. It will go up, tumor BED will remain same green. So 7 weeks gone. When the patient comes back, you deliver 8th week and the 9th week. And what will happen? You have to keep the dose per fraction for all these 10 fraction at 2.85 gray per fraction. That should be the size of the dose per fraction if you have to keep the tumor BED same at 67.8, or the normal tissue BED will go 19% higher, or it is equivalent to delivering a physical dose of 83.3. So these are the 4 different examples. Now there are certain gray areas. The first thing is that head and neck case examples are okay. That is what explained in that document. But in order to extend these examples to other type of tumors, we need to know the most appropriate alpha by beta values for various other tumors. And value of K, you remember that we used 0.9 gray per day. That is the loss. Is it same for all other tumors? No. From Dr. Orton's own words, he has used 0.1 BED for slow growing tumors, 0.3 BED for average growing tumors, this K value. And he has used only 0.6, not 0.9 for rapidly growing tumors, from Dr. Orton's own words. And T delay, is it constant 28 days for all sites? No. From one of the groups, see, like this is from St. Luke's Radiation Oncology Network from UK. Remember category 1 and category 2. So 1A, head and neck, squamous cell carcinoma, cervix, pediatrics, TBA, they are grouped together. And for this repopulation factor, they have kept it as 0.9, and T delay 28. For these type of tumors, they have kept the repopulation factor at 0.7 and T delay 25. And same value for these tumors also. But for prostate, 0.058 is the repopulation factor and T delay is 34. Now, there are certain management considerations, in the sense that when you want to treat on the weekend, you cannot just like that, you can start treating on weekend or treating twice daily. So you need machine and staff availability. You have to make logistical adjustments for that. So we need to have access to minimum of 2 linacs so as to keep the treatment gaps as minimal as possible. You have to have adequate staff so that they can come on Saturdays and Sundays. And you have to plan the machine breaks, like preventive maintenance, all those things. You have to plan it in such a way that it happens over weekend or something without affecting the patient. Schedule the planned machine breaks judiciously. Minimize the number of weekend breaks. That is, as far as possible, start the treatment on a week beginning, Monday, and avoid starting the treatment on other days. That way you can have less number of weekend breaks during the course of the treatment. And holidays, try to treat whenever there are holidays in between. Do not prolong it, and try to complete by treating on weekend or twice daily. Like in our hospital, whenever there is any kind of leave, we always treat on Saturdays for compensating for that holiday. And also another way by which you can control the treatment breaks is trying to identify the medical problems very early. So manage the reactions to reduce the risk of treatment delay. Nurses and technologists play a key role here, because they are the ones who are going to see the patient every day, and they can tell, oh, this patient is developing reactions, and if they bring it to your notice, then you can take some suitable actions in order to control the reactions. Psychological and social work support to patients and their families should be extended. Only few days delays, there are no problems, as we had seen in the examples. By resorting to treating on weekends or by treating twice, we can actually compensate for missing few days delays. However, this option is not for uh, patients who are receiving treatment with dose per fraction greater than 2.2 gray. We will have to use the biological correction, that is, we will have to use those equation when interruption occurs late in the treatment course, or when weekend treatments and BD treatments are not possible. We then will have to increase the total dose and or dose per fraction based on the radiobiological based calculations using those equations. However, whenever such changes occur in fractionation or in the dose schedule, these must be authorized by the radiation oncologist and justified by the consultant. It should be discussed with the patient and it should be documented in the patient records. Re-consent is a must. And when I talk to many of the doctors, they feel solutions may result in large dose per fraction. They are not comfortable with. And if you are not comfortable with, try to take a middle path. Particularly so when long gaps occur, then the fraction sizes can be very large. And in that case, try to take a middle path. And one another thing, this document, the RCR document doesn't say anything about the Dahanka guidelines, but Dahanka guidelines, the Danish ones, tell many other restraints. That is, there shall not be more than 13 continuous fractions. That is number one. Number two, avoid more than one extra fraction per week. In one of the solutions, I told that on 5 days, treat twice daily. That is not recommended in Dahanka guideline, but this is separate, completely separate. Avoid more than 3 days with BD fractions in 2 weeks, like that. When we are following TDF practice, I assume that in Bangladesh also this is the common practice to follow the TDF. When you are changing from TDF practice to LQ model, the change cannot happen overnight. So it will definitely pose challenges. That is because we have been all along under the comfort zone of the TDF. TDF, we all know that it is easy to calculate, easy to follow, and it doesn't involve managerial and clinical considerations. We don't have to bother about how to treat on Saturday or Sunday, or how to treat twice daily, because it's very easy to, it doesn't involve that kind of adjustments. It doesn't require balancing between options. It doesn't throw you that how do you, whether you want to follow tumor BED or normal tissue BED. So there is nothing like choosing between different options. And even for long gaps, easy solutions are there. Even if it is for 1 month, we can just easily find out, and we are not given with difficult choices. Nevertheless, we have to change over in this modern radiation oncology practice. When everything is very modern, there is no point in still sticking to the good old method. Even Dr. Arton, who is the inventor of this TDF method, has completely switched over to LQ model. There is no reason that why we should be following that. There are ready-made softwares are available. This TDF plan version 1.888. This is the link for this software. Very cheap. It's just only $20. You can import this uh, software for such a cheap price, $20. And the good thing about this particular software is that you can build a database for all your patient. You can have a database. We did our own Excel sheet. It's not as good as that particular software, but it will serve the purpose. Whatever that I have explained, we have done this Excel sheet like this. This is how it looks like: alpha by beta values, planned course, BED calculation. And then option one, I told you, preserve normal tissue BED. Here you have to give the values. The gray ones you cannot touch upon, only and also green ones you cannot touch upon. These amber colored cells only you can enter the value. The rest of the cells will be automatically filled up. Option two is preserve tumor BED. You can use this option, or balanced approach, that is compromising both on normal tissue and tumor tissue. Not only that, in our center we have developed this app I will be very glad to share this app with you. This is the link. I'm going to share this PowerPoint with you. You can download this app using this link, and if you have got any problem, you can always approach me. This is my WhatsApp number, or this is my email number, and you can see here when you open the app, this is how the front page looks like. You have to fill in the course details, and you have to either select preserve normal tissue BED or preserve tumor BED or a balanced approach. So here, this is the main page, opening page, and this is the course details. Here you give the course details and then preserve normal tissue BED, like that. Other pages will be there. To summarize, try to prevent interruptions as much as possible, identifying the reactions early and trying to intervening if necessary, and go for replanning, or treat on Monday to Friday, then you give some gap Tuesday to Saturday, and then again treat continuously. Counseling, try to counsel with the patient, tell how important that not to break the treatment. Schedule the machine maintenance without affecting treatments. And if gap occurs, try to minimize the duration of the gap. Even days matter. Remember, it will be difficult to manage gaps more than 2 weeks. Many times people ask me, what is the solution if the patient is absent for 2 months or 1.5 months or 1 month? It's not possible to find out an acceptable solution, especially for squamous cell carcinoma cases when the treatment gaps are very long. To address the gap, explore all possible solutions and decide on the best one, and as short as reasonably achievable. That is the Makilov's Asara principle. Try to maintain as short as reasonably achievable. As much as possible, start on a Monday, that is week beginning day. That will give you less number of weekends during the treatment course, and try to collect the data on alpha by beta ratios for different tumors and normal tissues. And every department must have an audit system. If you have an audit system, you will be surprised to find out that on how many patients you have inadvertently missed on maintaining the overall treatment time. So your audit system must be able to check whether the patients having fast proliferating tumors, whether they complete their treatment course within the planned overall treatment time. And thank you very much for your attention. And that's the hospital where I am working, and I will be very glad to take questions. Actually, I have got that Excel sheet. If there is time and if you are wanting, I can demonstrate that Excel sheet also. But otherwise, you can also easily work on that Excel sheet, and I will be always there to help you out. Thank you very much.
Thank you, Dr. T. Ganesh. I think it was a wonderful lecture. To be very honest, before listening to it, I never realized that it is so helpful for even me and every radiation oncologist. I was thinking that it is the story of the physicist. I will be joining as a courtesy. But I now realize that it's more important for a radiation oncologist than a physicist. Thank you very, very much. It was very helpful.
Actually, my main focus, and I am trying to convey this document, what the document says to all radiation oncologists. My main focus is radiation oncologists.
Yeah, that I realized. Even I was with Karthik in organizing, but my confession is, I was thinking that, well, it is more a physics staff. So as an organizer, I was joining as a courtesy, but
Yes.
Thank God I realized and I joined. Otherwise, I would have missed a great lecture, and it was quite educational. So I think there must be some many questions. So I shall request one after another to. So there was some question in the chat box,
Yes.
but Karthik, can you help? Because I was disconnected in between, so I lost some of the questions.
Yeah,
Can you-
Conrad, I'll take over, no
Yeah,
problem.
please.
Sir, before getting into the questions, I have need some few clarifications.
Yes.
Normally, we are talking about the, the radiation biological effective dosing, but most of the times, this, the side effects happens because of the concurrent chemo. Most of the times, this, the way of approach, what they have used, like compared to the TDF and the LQ model, and they are not considered about the concurrent chemo effect on the side effects.
Yes.
Uh, And sir, most of the times, the problem is, we have still in subcontinent like Bangladesh and India, we are talking about side effect means, heavy side effects. Okay, like skin reactions, grade 3, grade 4,
Yes, yes.
and we stop about for a week, and again you go for an, increase your dose per fraction, or the dose per fraction for 2 days, and we give an two fractions in a day. Whether this kind of a system will be applicable for Indian and Bangladesh conditions, it's a gray area. Obviously, I understand, but
Yes.
it's difficult to approach. You can increase the number of fractions or increase the dose per fractions. It's we cannot just accommodate within some certain times. We need to take time to approach this approach.
Yes, I completely agree, and especially in our countries, India and Bangladesh, situation is totally different from the situation that exists in advanced countries. I agree, but at the same time, what I say is that uh, as I showed in my last slides, the switchover is not going to be overnight or complete. What I'm telling, try to take a balanced approach as much as possible. Okay, you don't have to tilt to completely to very high increased dose, but do whatever within your possible limits. Try to slightly alter and try to control the loss in tumor BED to the extent possible, to the extent that you feel comfortable as a radiation oncologist. So as a radiation oncologist, how much risk that you can take so as that not to have a very high reaction, but at the same time not to lose too much on tumor BED. So as a treating consultant, you are the best person to see the patient and judge that up to what extent that I can go.
Karthik,
Okay,
if you
sir.
are,
I think we can go into the questions. Kalbai,
sorry.
tell me.
So I my comment, it was my question in the chat box
Yeah,
about
yeah.
that we are going to increase the dose per fraction or going a BID dose, what is going to happen to the toxicity?
Yes.
So
Yeah,
my
yeah,
take
we'll go to the
is,
questions. Yeah.
yeah, my take on this part as a radiation oncologist is that I'm more concerned about the acute toxicity than the late toxicity, because I can manage the toxicity, but I want a cure. At a cost of toxicity, I'm ready to take the cure. So I will be making a balance more on the acute toxicity, which may again make interruption in the treatment rather than concerned about the late toxicity. Because I know that I have treated this patient with some higher dose per fraction, which I am apprehending some late toxicity. We can take a prophylactic measure or I can counsel the patient. But I agree with you that with concurrent and with BID dose or such as a 2.7 or 2.6 gray per fraction, maybe I'm scared for the skin toxicities and it may again make a gap. So as if you ask me as a radiation oncologist, my take will be, I will making a balance what Dr. T. Ganesh said, that in between, so that my concern will be more on the acute toxicity because I don't want another gap with this.
Yes.
So as I walked in, so I have one question directly to Dr. T. Ganesh. So whatever calculation you have shown,
Yes.
many of our participants are from some centers who are dealing with cobalt. So will it be
Okay.
the same applicable formula for cobalt L9?
Yeah, yeah. There is no difference between the energies or anything. This is just based on the radiation dose. It has nothing to do with LINAC or cobalt. Nothing on that. It is all applicable. It's all same for all energies.
Okay, Karthik, you can take over. Karthik?
Yeah. Okay, there's a question from Kalbai. You're able to listen?
Yeah, you
Hello.
can carry on. You can take over.
Yeah. There's a question from Mohammed Astakar Hussain. Okay. Before lockdown, one patient received 10 fractions. When lockdown lift, then he came after 2 months for remaining fraction. What will happen? He has not mentioned which site and what is the dose per fraction, but
Yes.
still, sir, you can
So why not,
comment
Dr.
on it.
You ask the question with your specific
Yeah.
what like. Dr.
Uh,
You are there.
actually,
Thank you very much for.
yes.
Suppose it is a head neck cancer.
Huh. This question actually, this is
Or
my,
cervical cancer.
yeah, this is my fourth presentation or fifth presentation, same thing I presented to Saudi Arabia twice and then India twice or thrice like that. Anyway, whenever I presented during this pandemic period only, this was one of the commonest questions that I was asked, that if the patient receives a certain number of fractions before the lockdown and after the lockdown patient coming after 2 months, well, it first of all it depends on what type of tumor that we are dealing with, if it is a slow proliferating tumor or fast proliferating tumor. If it is a fast proliferating tumor, then we don't have any other choice. It is after 2 months, what is left out for the tumor, practically almost nothing would be left out. Everything would have evaporated, so-called evaporated, all the dose. But normal tissue is not going to forget the dose. It is going to remember the dose very much. However, Orton has used, even for normal tissue, he has used a K factor of 0.1, very low K factor, but still he has used a factor of 0.1. So it depends. You have to see that how much in a safe way that you can give. Whatever the document has shown, those four examples, they have shown only for limited gap. They have not told how to address a long gap. It has not been dealt with, perhaps because it was developed by UK, and in UK it's very rare to come across such type of long gaps. So they have not told. I feel that we cannot apply this methodology for long treatment gaps. It would give very unacceptable results.
So that is too for cervix, if you are talking.
Your voice is low. Hello.
Hello.
Yeah, sir. Ganesh sir, there is another question. From Asma Siddiqui, after 2 weeks of ABRT treatment in cervical cancer, there was a 3 weeks gap. What to do?
Oh, that Excel sheet, actually, just to fill up the values. Can I share my Excel sheet?
Yeah.
Yes, please share this.
Yeah, I think it will be a good idea, sir. Sure.
So just wait, share my screen and Excel sheet. Okay. So can you see my screen?
Yeah, we can see the screen, sir.
So what happened? Okay. So here normal tissue value alpha by beta 3 I put, and here I put 10, and the treatment site here I select, which is that one you said, cervix.
Cervix, sir. Yes, sir. I think in the third one, sir. Yeah.
And the total dose, how much? 60 gray?
Just assume, sir, we'll pay 50 gray and 25 fractions, sir.
Okay, 50 gray, and then 25.
And after 2 weeks, yeah, okay. Number of fractions 25.
No, that is number of fractions. This is the planned course. So 25, and then
right,
treatment start date. So actually we have to have the calendar. When did it start? So we have to enter the date. For example, I gave earlier an example, 3rd February. So you have to enter when you are using the Excel sheet. Kindly remember, this is how you have to enter the date. If it is February 3, 2020, just enter like this: Feb space 3, comma 20, 2-digit year. This is how we have to enter. Otherwise, there may be some error in the Excel sheet. Please enter the date in this format only: Feb space 3, comma and year 20. So the moment you put it like that, planned completion date for 25 fraction, it automatically calculates 6th March, and planned overall treatment duration is 32, and onset of proliferation T delay for this CA cervix is 28 days. K factor for the tumor is 0.9, and delivered number of fraction. How many number of fractions delivered before the gap?
10. 10.
Yeah,
10.
I mean 10 fractions.
Okay,
10
10.
fractions, sir.
So 10
10 fractions.
number of
Yeah.
remaining fraction is 15, and the planned normal tissue is 83.3, planned tumor tissue BED is 56.4. Until 10 fraction, we have delivered a BED, normal tissue BED of 33.3 out of this 83.3. Okay. So now option 1, number of fractions in which the remaining course to be delivered. You see here, the remaining fraction is 15. So you can deliver the remaining treatment course over 15 fraction, that is extending by another 3 weeks. Or if you want to play around, you can put 14 fraction, 13 fraction, 12 fraction, or 10 fraction, like that. This is your choice. So here you put 10 fraction. And if you put 10 fraction, then you have to enter. So automatically it has calculated if normal tissue BED is to be maintained, dose per fraction should be 2.65 gray per fraction. What is the tumor BED loss? It is not able to calculate. That is because you have not given the overall treatment duration. So you have to, for these planned 10 fraction, you have to give the start date and when it is going to end. So with the calendar, you have to work it out. Now you want to deliver the 15 fraction in 10 fraction itself. When the patient has started the treatment subsequent to the gap, you enter it here. And if it is 10 fraction, mark on the calendar if it is starting on fraction 1, 2, 3, like that 10, when it will end, you put the end date here, then these values will be filled. Or if you want to preserve the tumor tissue BED, similarly, you can enter here number of fractions in which remaining course to be delivered. You can put it as, say, like 12. Oh. And again, once again, you have to enter treatment will restart after the gap on what date. You have to enter treatment will complete on which day you have to enter. So with the calendar, if you enter, then in these green cells, you will get the results. I will be sharing this Excel sheet to all of you, and you can use for your clinical example, then you will come to know. And whatever Arton has stated, I have mentioned it here. So please go through this. This is straight from Arton's mouth, in the sense that he has actually written these lines in a group email. Okay. And also you can download that app which I had shown. Using that link, you can download it on your mobile and straight away use from your mobile itself. Yeah, Karthik.
Sir, there is another question, sir, from Mr. Mohammed Anwarul Islam. Sometimes the patient interrupted treatment by their own choice and come again after 1 month. How to manage this?
I mean,
I think it will work with the same way.
whether the treatment gap is due to patient's own reason, like patient remaining absent or patient went to some other outstation, something like that, or it is due to some other reason, that is immaterial. What matters is that what is your planned overall treatment time, and how much was the gap, and when the patient reported after the gap, and then how do you want to manage the further. So it has nothing to do with what is the reason for the gap.
So I have a question, Dr. Tiga.
Sir.
So as Karthik was mentioning that this calculation is considering the concurrent or it is based on
No,
only.
no. It doesn't consider concurrent or anything. No, it doesn't take into account
So
that.
does it going to affect the, say we are treating a head neck, normally always it is concurrent. So
Yes.
is there anything we need to adjust or we follow this formula?
No, that RCR document doesn't say anything about that concurrent.
Okay, my next question is, say we have a big problem in our country about the cervical cancer. After EBRT, there is a big gap of brachytherapy for many reasons.
Oh.
Sometimes for the availability, sometimes for the ignorance. So what is your comment? Say we finished 50 gray, 25 fraction, and then let me show you three scenario. One, we give subsequent every week 4 fraction, 7 gray into 4 fraction, or I give 2 fraction per week in 2 weeks, or I finish the brachytherapy along with the radiotherapy, and I finish all the treatment within say 5 weeks plus 4-day time. So is it going to make a difference on the total BD of the point A dose?
Once again, the RCR document doesn't say anything about the brachytherapy. It simply says that whether it is for EBRT or EBRT plus brachytherapy, it simply states that the planned treatment course should be delivered or completed within the planned overall treatment time. In other words, what it says is that when you start external beam therapy, if the patient has been planned for brachytherapy as well, we know on which day it has to be completed, and within that time we have to complete. But beyond that, it doesn't say anything that how to manage. I have one another document which also is very vague about how to manage the brachytherapy gaps or any other thing. It simply says that you have to complete it within the planned overall treatment time. Initially, if you have planned EBRT 2 weeks gap, then followed by brachytherapy, and if there is any gap, they say that okay, now reduce the gap. Instead of the 2 weeks gap, reduce it to 1 week or reduce it to few days only, like that.
So one more question, we are talking about various, we have a success with IMIT and VMAT, where normally the toxicities are, skin toxicities are less, compared with the cobalt units and other things. If you assume, okay, we are working in a cobalt unit and we have a stage 3 or a stage 4, grade 3 or grade 4 skin toxicity. As a physicist, you will go with, increase the number of fractions, or you given 2 fractions per day, or increase the dose per fraction, you will agree with it if you are treating with a cobalt unit.
No, I think
it's a head and neck cancer.
No. I think the choice that how to go about is the choice. The choice should be made by the treating consultant. Physicists can work out and offer the solutions. Where we can go option 1 this way, option 2, or option 3. But the final decision only the treating consultant has to take after considering all the clinical conditions of the patient and the clinical scenario, actual clinical scenario.
So Dr. Ganesh, regarding the BID treatment, we know that minimum 6 hours gap is recommended.
Yes,
is
yes.
there any additional benefit we are getting if we are making the gap of 8 hours or 10 hours? BID, once I am planning.
Yeah. But there may be definitely, because treating twice a day, even with 6 hours gap, is not the same as giving that 24 hours gap. So I feel that giving 8 hours or 10 hours gap instead of 6 hours is definitely beneficial. It will be better than, that is, treating after 10 hours or treating after 8 hours will certainly be better than treating after 6 hours, but it has not been quantified or told any other thing. And
But
only
we should
problem is
give-
that it will be difficult to manage it, because if you are going to treat after 10 hours, that means that we have to work during very late hours. Hello?
Sir, I think we don't have any other questions. Kamal bhai, I think we can conclude it.
Yeah,
Yeah.
Kamal
I
bhai?
think we can conclude, but I shall appreciate if anybody else want to ask any question, because I think it is a unique opportunity to get Dr. T. Ganesh like this on the hot seat and ask any other question. And I think every single radiation oncologist in their life experience this gap, and it is mandatory in our life. We never, nobody is immune of this gap. So anybody, if no question, then we can conclude. Is there anybody want to ask any question? I want to invite.
I want to say something.
Yes, Tapush.
I think we should congratulate Mr. T. Ganesh. It is a wonderful presentation I have ever seen. But we something sometimes of a presentation we have seen, but we cannot understand. But today I have understand many more things from him. I first congratulate him, and this is my great opportunity to Mr. Ganesh for such a wonderful presentation.
Thank you, sir.
We have discussed a lot. I think we have discussed a lot, and during in our country that sometimes the present patients do not come at the same time. That is on the in our country it is from Saturday to Thursday.
Yeah.
In our country, we are treating the patients. They do not come in the Saturday. They may come on the Tuesday or Friday or Thursday. Can this can we shift these patients for the next Saturday? Then the gap will be another a very this gap will be more. I think if the patient come on the instead of Saturday, they come on the Sunday or Monday. Can we shift this patient on the next Saturday? As you told that it should start from the Saturday. It will be more beneficial.
No, actually, try your best to start it, but if the patient is coming on Sunday or Monday instead of Saturday, which is the week beginning day, no problem. What I'm telling, try your best. If it is not possible, don't delay. You are delaying another 4 days means then actually tumor will be proliferating much. However, proliferation takes place only after start of the treatment. So depending on the clinical case, you can take a decision. See that T delay 28 days, which I had mentioned from the document, that is the proliferation of the tumor which starts after the start of the treatment course.
And the treatment is on the Friday. Is it possible, feasible? This is the holiday. So you have.
That's why that is a logistical question. So either you can adopt for that. Let me point out here something that in UK, where this document is from Royal College of Radiology, and 100% of the centers, 100% of the centers, I had talked to many of my friends in UK. It is a crime if this document is not followed in any of the centers. That particular center will have to be answerable to NHS if they do not follow. It is a must that every center must follow this. So they follow in and out this document, all the centers invariably. So every center has got an arrangement to treat the patients on weekends, or if that is not possible, to treat twice a day. So they are having a certain mechanism. So it is definitely problem to treat on weekends, but that is a logistical issue. This is the solution. How to implement it, that we have to work it out.
Okay, thank you, sir. Thank you.
Yeah, thank you.
So I think, Karthik, we were scheduled for 1 hour. It is, I think, almost 1.5 hours. So we can wrap it up here. So I want to make a personal request to Dr. T. Ganesh
Sure, sure.
that I heard one of his lecture on how to evaluate a plan and on DVH. And this is one of the best lecture that I heard on plan evaluation and DVH. So if you agree, we can arrange a similar program sometimes
Yeah.
when you can give a lecture on DVH and plan evaluation. That I heard even in Bangladesh. But I think it will be very helpful for our colleagues to, if you don't need to give the time now, me and Karthik will contact with you.
Sure,
In your
sure.
busy schedule, if you can give a time, something like this, for an
Yeah.
hour, we can have a discussion.
Oh, sure, sure, definitely, no problem.
Okay. So with this, I want to thank Dr. T. Ganesh and Karthik personally because he took the initiative to arrange this thing, and to all the participants who made the program successful, and with their interaction, it was lively. And finally, I want to tell that all this lecture link will be sent to all the participants by their email, and we will send you the PDF of the presentation and also the Excel sheet that he showed. So you will get the resources. And now I would like to request Karthik, would you like to say a few words, or?
No, come by. I think you can conclude it. Not a problem. It's all.
Yeah.
Okay, sir. Hi, sir. Would you mind to finish it, sir?
Okay, thank you. Thanks to our speaker, Dr. Ganesh. It was really a wonderful lecture.
Thank you very much, sir.
And thanks very much for giving us your time, valuable time. Our boys must have been benefited with the lecture. Hopefully, we shall try to follow your instructions. And also thanks to Zakaria. If you are still,
Sir, I think he left. Dr. Zakaria left. He sent a message, but I
so-
saw he left.
okay, fine. So we had a nice discussion today. We're already late. So goodbye, everybody. Thank you all very much.
Thank you
Goodbye,
very
bye
much.
bye.
Thank you.
Thank you. Thank you.
See you again,
Thanks
Ganesh.
a lot, sir.
Thank you. Thank you.
So
Thank
we
you
will
very
be
much.
waiting to listen to your another lecture very soon
Sure,
on
sure, sure.
DH and plan evaluation.
Yeah.
That in that case, you will include the oncologist also.
Sir, this time all oncologists were invited, sir, but many of them maybe thought like me that it is a physics.
Possibly could not make
No,
time.
come by. I think the registration was more than 90. You know, somehow
Yeah,
they
there was
attend
90
around 40.
registration, sir. For some
Yeah.
reason, participation is 37, but we had 90 registrations, sir. But you know, so many programs going on today. This is the third.
Yeah,
Too many webinars, yes.
You get too many webinars. Yeah. So thank you, Dr. Ganesh,
Thank
again.
you. Thank you. Thank
Sir,
you.
Hopefully
Thank you very much. Thank
virtually
you.
soon and physically also soon.
Thank
Karthik
you.
also. Much thanks to Karthik.
Thank
Thank
you.
you, sir. Thank you.
Thank
Thanks a
you.
lot, sir.
Thank you. Thank you.
Thank you. Bye.
Bye. Bye.
Samir, send the presentation to all by mail and the link of the recorded version.
Sure, sir.
Okay, bye then, everybody.
Bye.